All right, good afternoon. We're going to get started. For those who don't know me, my name is Scott Siegel. I'm at the Value Institute. I'm just filling in for Claudine, who couldn't be here today, to introduce our speakers. But before I do, a few housekeeping items. Welcome to the Innovation Discovery Series. Instructions to obtain CME credit are on the screen. We can also, if you're not able to get that down, we can email you instructions if you provide your address on the sign-in sheet. I also want to make you aware of two talks coming up. One is on July 12th with Dr. Danielle Shearer from MUSC, who will be talking about the intersection of high reliability and value in healthcare. You can register through the CCHS portal, and you can also find the full ID series schedule at the ACCEL DelawareCTR.org website. And then one other one I want to bring your attention to: on September 5th, we're going to have a tech talk presented by Dr. Jobair Hossein from Nemours. And the title of that talk is The Classification of Distinct Trajectories in Unbalanced Longitudinal Data, Growth Mixture Models versus Clustering, the LUPs from Mixed Effects Models. We were just talking about that, right, Lisa?
Oh, yeah.
Okay, so without further ado, I'd like to introduce our speakers for today. And it's actually a nice privilege for me to be able to do this because in a very small way, I'm able to be a part of the Project CANDOR program. So our first speaker is Dr. Perlman, who joined Christiana Care as a staff neonatologist after completing his fellowship at Penn State Hershey. He's held multiple leadership positions within the Department of Pediatrics, including Associate Director of Neonatology, the Director of Pediatric Medical Education, and he served as the Neonatology Fellowship Director. In 2012, he received a Master of Science in Healthcare Quality and Safety from the Jefferson School of Population Health, and he is currently the Quality and Safety Officer here at Christiana Care. He's also a clinical professor of pediatrics at the Sidney Kimmel College of Medicine and serves as an associate editor for the Journal of Perinatology. He has published 80 abstracts, papers, and book chapters. He lectures nationally and internationally on a number of topics related to quality improvement and services, and serves as the course director for Quality Improvement Day, the Hot Topics in Neonatology meeting in Washington, D.C. Finally, he's also involved in activities at the American Academy of Pediatrics and served as the chair of Neonatal Coding Committee and is currently a member of the Committee on Child Health Financing. I'd also like to introduce Michelle Campbell, who is the Vice President for Quality and Safety. She has corporate responsibility for Christiana Care's Quality and Patient Safety Program, as well as continuous regulatory readiness. Ms. Campbell leads a team of quality safety professionals working collaboratively with clinical leaders to advance process improvements in patient safety. She has been instrumental in leading our journey to zero harm and creating a culture of safety. She has also led successful achievement of the Gold Seal of Approval from the Joint Commission for Acute Care, Behavioral Health, and Disease-Specific Program Certification, including the Heart Failure, Hip, Knee, Primary Stroke, Comprehensive Stroke, Acute Stroke, Ready Hospital, and Left Ventricular Device Programs in collaboration with the senior leadership team. I also learned that Michelle loves long walks on the beach, where she will be darting off to right after this talk. And then finally, Susan Perna is the Director of Risk Management at Christiana Care Health System. In her role, she is responsible for risk management activities across the health system. She manages the claims program and coordinates claims handling activities with the claim administrators and defense counsel. She participates in managing all lines of insurance coverage for the health system. Susan joined Christiana Care as a nurse in the neurosurgical unit in 1996. She joined the Legal Risk Management Department as a risk manager. She was promoted to Director of Risk Management in 2008. She graduated from the University of Delaware, where she received her BSN and MS, and she is a certified professional in healthcare risk management. So with that, please give our speakers a nice welcome.
Thank you very much, and I want to thank folks who organized this for inviting us to come share our experience with you today about a program that we're very proud of here at Christiana Care that really represents a collaborative effort between patient safety, risk management, and patient relations. Some of my colleagues are here today, and we would not be able to do the work without all of them participating and helping out, and I want to publicly acknowledge all of them. There are too many of them to acknowledge individually, but I do want to shout out at least one person, Pete Ladato, who's sitting there. I think you guys probably know Pete because he came from the Value Institute beforehand, and he pulled together a lot of the information that we'll be presenting to you today. So it all starts with excellence and love, and those are our values and behaviors. And really, I think you'll see how this program, which is about being more transparent with our patients and their families when there are unexpected outcomes, I think you'll see how that fits in very strongly with the values that we espouse here at Christiana Care. See if this clicker works. It does. So CANDOR stands for Communication and Optimal Resolution, and you've already had way too extensive introductions about myself and Michelle and Susan in terms of our backgrounds. So the goals for today's presentation will be to kind of give you an overview of these types of programs and give you some examples and some of the data about what has happened in other organizations. We'll discuss the components of it and how we do it here at Christiana Care, what our process is, what some of our outcome metrics have been so far, and then finally we'll finish up with some opportunities for additional things that we'd like to add to the program, refine about the program, and maybe with your input, the types of metrics maybe that we could be looking at in the future. So in terms of the background and history, the very first part of this, I'd like Michelle to speak about how the CANDOR program fits into our overall strategy of trying to get to zero harm. Now, are we being broadcast anywhere else? We are, so we have to stand by the mic.
Okay.
I don't really have to.
Okay.
They can hear you.
Okay. All right. So thank you. First, with any patient safety efforts, we really need to recognize the landmark report to err as human. And with that, I think all of us may remember that's 20 years ago. That it's really about patient safety and medical error. And really what that article published was that there's between 44,000 and 98,000 deaths per year from medical errors. And when it first came out, they really equated that to a Boeing 747, a full Boeing 747 crashing every day. So it had tremendous impact on the healthcare environment. It was published in the USA Today, the Wall Street Journal, the Washington Post, really served as an impetus of what the safety movement is. And from that, they really generated some evidence-based interventions that would be working through to improve patient safety efforts. One of them really was some of it was the deployment of a rapid response team. The other one was really prevention of central line infections. So with that, we are happy to say here at Christiana that we've been really working very diligently with that implementation. As of today, I think it's 98 days free from CLAPSI or central line infections for the entire organization. So 5-10 years ago, we never said we wouldn't have even dreamed that we could have done that, but we're doing it. And it's thanks to all of the hard work from our frontline caregivers here. And then relatively new is the safety science and then high reliability. So as the safety movement started, we looked elsewhere. We looked at other organizations that had remarkable success from a safety perspective. It was the nuclear power, it was airline industry. We looked at that and said, what could we learn from them? They have phenomenal safety records. And started to adopt some of those interventions. Team training, speaking up, allowing, deferring to expertise related to a particular item. And then certainly with safety, the culture really enhances whether or not you can achieve that high reliability. And then one example here, we also have executive safety leadership walk-rounds, where we really meet with the frontline caregivers. And we want to know two things. The first thing we really want to talk about, so what's going well? What are the three things or things that you can tell us that from a patient safety perspective, we're really doing well? And the second component is, so what are the things that you might be seeing and we may not be aware of? Frontline, you're seeing every day. What are the opportunities? Some of them are simple things. We had a transporter say to us, well, the elevator door closes every time I'm transporting the patient and I'm by myself. So we found out we could retime that elevator so that the door doesn't close. So it's really important from a culture perspective to really maximize what the front line is hearing. And then certainly our report to learn. We have our system that in other organizations would be called your traditional incident reporting system. But we actually coined the term report to learn because that's truly what we want to do. We want to seek new knowledge. We want to make sure that we're learning from our events. We're very transparent. And that's really what enables us to even activate the CANDOR program, as Dr. Perlman's going to describe to you. So with that, Dr. Perlman.
Yeah, I just want to echo one thing that Michelle said, which is that, you know, when I went through my medical training, we were taught, you know, that complications happened, and they happened with a certain frequency, and that was just par for the course. We had to accept that. I think that mentality began to change in 1999, and as Michelle mentioned, to think today that we're sitting here with 3 months plus without an infection from a central line in this institution is something that 10 or 20 years ago people could not have possibly envisioned. So the things that I was taught are just par for the course. I think now you have to think about all of those complications differently. But that's not what we're going to talk about today. We're going to talk about how we handle it when we do have unexpected outcomes. And the origins of this actually start around the same time as the report that was already mentioned by Michelle. In 1999, the Lexington Veterans Administration Hospital began a program where when a patient had an unexpected outcome that may or may not have been due to something that we did or didn't do to the patient, they would disclose that to the patient, they would review it, and they had some very striking results when they did that by being more transparent with their patients and their patient's family. Part of the driving force behind the CANDOR program was certainly the malpractice environment in this country. And I think everybody here knows what that's all about. It was sort of labeled as a crisis back in 2001. And partially as a result of that, too, the University of Michigan, probably more so than the Lexington VA, was really one of the first and most innovative programs in terms of communicating these types of things with patients. And we'll show you some of their program information and their data. Then two relatively or not maybe extremely well-known senators by the name of Obama and Clinton in 2005 actually tried to pass legislation, the Medical Error Disclosure and Compensation Act, but it failed. And but Obama was to have his revenge. He said, "I know what I'll do. I'll get myself elected president, and then I'll be able to do this." So that's what he did. Actually, we know he became president, but then he really felt very strongly about this issue. So in 2009, he asked for the Agency for Healthcare Research and Quality, AHRQ, to give a demonstration grant to have people start to work on these types of programs. And the University of Illinois at Chicago was one of the organizations to organize that, and they had done the project a few years before, so they were given the grant to develop this further. And we here at Christiana were extremely fortunate to be a part of that initial demonstration project back in 2014. We'll talk a little bit more about that. So again, the timeline, 2005, University of Illinois at Chicago created their program. In 2009, President Obama directed ARC to develop the grant. In 2013, there was that grant, and then from there, the demonstration project at 4 hospitals, which actually 3 hospital systems. We were one of 3 hospital systems. MedStar down in Washington, D.C., us, and Dignity Healthcare out in California. So we were pretty lucky. And actually, as I recall, it was Senator Carper at the time who had a lot to do with getting us. He was on some committee to do with healthcare, and he was instrumental in getting Christiana Care's foot in the door to be part of that demonstration project. So we were, I think, very lucky to be a part of that, and as a result, we're kind of ahead of many other places in terms of developing a program of this type. So that's too many clicks. Okay, what is a CANDOR event? It is when an adverse event is when there's a patient safety event that results in harm to the patient. And again, this can be a known complication of a certain type of procedure or what have you, or it could be due to the fact that somebody did something improperly, or that there was a system failure that resulted in that harm. And a CANDOR event, we have defined here, and I thank the people who made that decision many years ago, every single day for this. We defined it as patients who had experienced either permanent harm or death. And the reason why I say I'm thankful that we made that decision is you're going to see the volume of cases that we've had to deal with over the last 3 years just from these criteria alone. And, if we had included everything, like everything down to an infiltrated IV or something like that, we certainly would have been overwhelmed. And to the credit of the patient safety department, as well as risk management and patient relations, we took this responsibility on because we thought that it was the right thing to do, but none of those departments were given additional resources to try to help develop and create this program. So kudos to them. So here's an example for you. This is not a real example from here, but it's an example that has been described elsewhere. As an elderly patient came to the ED complaining of shortness of breath and had a history of COPD, atrial fibrillation, congestive heart failure, and coronary artery disease. She was treated in the ED and then was in the boarding area waiting to get placed into a bed, which frequently happens in our ED. And 6 hours later, she suddenly became unresponsive or less responsive, bradycardic, and was breathing very shallowly. She had been made a DNR. She was given some atropine without success, and she expired. When this case was reviewed by the pharmacy, what they learned was that the medication history was performed on 2 patients at the same time, and they inadvertently got switched. And so this resulted in incorrect medications being given to the patient. And then the patient ended up receiving 8 incorrect medications and 3 medications that were the right medications but the wrong dosage. So this is the type of thing that's a system failure, right? It wasn't any one individual that resulted in death of a patient. These things happen. So this schematic here kind of takes you through the various steps, and we're going to talk about each of these steps in a little bit more detail. First, a case is identified as being CANDOR. Now, sometimes that might be due to somebody placing an R2L report, which Michelle just mentioned, about an event that occurred and they had some concerns related to it. Sometimes a department or a nurse or a physician or somebody might reach out to the risk management department directly or to the patient safety department with a particular event that they're concerned about. And there have been some very unusual ways that we've sometimes found out about cases. One case in particular that I think of came to us because we got an autopsy report back on a patient, and the diagnosis was, on the conclusion of the autopsy, was a diagnosis that was completely different from the patient's diagnosis before death. So in other words, it was a misdiagnosis, but we found out about it after the fact. Once we find out about the event, then we activate the CANDOR system. We have a group phone call that involves many people, nurse and physician leadership from that particular part of the hospital, risk, patient safety, patient relations, care for the caregiver, and others. And we discuss the case and what initial facts we know about the case. We know very little at the beginning. We don't know. We just know that the outcome was unexpected. Sometimes there's information that comes to us that, we do have a little bit more insight into perhaps why something occurred, but it's really very superficial information at the initial discussion. And then that leads to the initial disclosure. So we tell patients and or families, depending upon the situation, that we are going to be reviewing the case more because the outcome that the patient had was not what we expected. And at the same time, we begin our robust process of reviewing the case and analyzing everything. And that involves usually a debrief where people get together who were directly involved in the patient care and share what they know about it. Patient relations talks to the family and see if they have any insights. Risk management, besides participating in the debrief process themselves, reaches out to people on an individual basis. Sometimes we find out information from individuals that they were not willing to share in the group setting. And once all of that is done, then the case is presented to a multidisciplinary group of physicians and nurses from all different fields in the hospital. That's also where Scott talked about his involvement, because he does serve on the CANDOR panel. And that panel hears the facts of the case, what we learned by our review, and decides based on that whether they think the care we gave met the standards that are out there for that particular situation, diagnosis, et cetera, and also whether the harm to the patient occurred as a direct result of the care that we provided, or was it instead due to the underlying diseases or disease that the patient had? And that's not an easy question to answer. That's challenging. So just to review again, the critical components: the event management, review and analysis. We look for process improvements that we can make. It's really about our commitment as a learning institution. Communication, the initial disclosure, subsequent discussions that we have mostly between patient relations and the family while we're completing our review. And then at the end, after we've gone to the CANDOR panel and people have voted on how they think the care contributed to the harm or not, then we have a family meeting where we meet back with the families and share what we learned with them. Care for the caregiver is an essential component of this program. It is headed up by Heather Farley, who's the medical director for that program and for physician well-being. And Katie, sitting back there, has been introduced in a lot of meetings this week. It's her first week with us, and she is the new program director for the Care for the Caregiver program. But we're here to this is not easy when people are involved in these types of events. They talk about physicians, nurses, respiratory therapists, other caregivers being the second victim in these situations. And we have developed this strong program to support people through these types of events. And then the resolution phase, again, we meet back with the family, discuss our findings. We don't discuss any sort of compensation there, but if based on our evaluation of the situation, we did not meet the standard and the care that we gave contributed to the harm, then risk management together with the legal department and our insurance carrier have subsequent discussions with the family about compensation. That's really the way these programs are supposed to be carried out. So let me just briefly go through some of the literature that's already out there about these types of programs. So this is one of the first papers that was published by the University of Michigan about their experience, and what it showed quite that you can see from the bar graph is that the litigation costs went down from $3 million to $1 million. The average time to the resolution went down by more than half, and the number of claims and lawsuits went down again by more than half. And their philosophy was apologize and learn when we're wrong, explain and vigorously defend when we're right, and view court as the last resort. So I can tell you that there was one particular case here that involved 4 different physicians that we ended up settling that with the family without ever going to court. And I'm not privy to the information about what the settlement was, but I can tell you, that commercial, I think it's for MasterCard or something, priceless. Keeping 4 physicians out of the courtroom and probably countless nurses and other caregivers also, that is priceless, because that is an extraordinarily stressful situation for people. So we did the right thing, and we also made it better for our employees. This just very quickly shows the model. This was University of Michigan's old model there on the left, and what you can see is basically they waited to get sued. They didn't do any investigation or review of the care prior to that. The litigation was really the starting point of the process, and then it was more of a deny and defend approach. And then they changed their whole approach, and I'm not going to go into all the details of it, but they had various committees and what have you. But basically, what they looked at was trying to improve, do quality improvement out of these events, see what educational opportunities there were, look at the peer review components, and really the whole focus of their process became quite different from what it was beforehand, that these were learning opportunities. What's another study? This is from the VA in Lexington, Kentucky. They were able to see a marked decrease in the size of settlements and also the time to settlements. So their settlements went down to 16,000 from an average of 98,000 in other similar VA hospitals, and they had only 2 lawsuits that went to trial over a 10-year period. But to give you a little bit of a balanced view here, there are some other articles out there that say that disclosure programs may not necessarily decrease litigation or litigation costs. There was one published in Health Affairs in 2007. The Stanford Law Review published an article, and it was really not about disclosure programs per se. It was more about states that have apology laws that say if you apologize to a patient, that can't be held against you subsequently. What that article, or it's actually was more like a chapter, it was a very long paper, found that apology laws by themselves really do not guarantee a decrease in litigation and costs, but really more robust training around this is what's necessary. So we think we're still on the right track with these programs. And, part of it is, risk mitigation in terms of lawsuits and what have you. But we also think, again, going back to our core values, that this is the right thing to do for our patients and their families. University of Illinois at Chicago published their results in 2016. They showed in this first graph a marked increase in reporting. So the fact that people knew that reporting was going to lead to important results and review of care and process improvement made people want to report things more. This next one is the increase in event analysis that occurred over the time period they were looking at. from 2007, I think, to 2014. This next graph shows the number of claims that went down during that same time period. And then this is the number of lawsuits going down. They also saw a decrease in the cost per claim, decrease in settlement costs, and decrease in self-insurance costs. And these changes that they saw persisted even 7 years after they initially intervened and changed their approach to these events. Then there were some other studies that were published in the last couple of years. One by Mello in Health Affairs looked at the outcomes at 2 Massachusetts hospitals, and their criteria for reviewing these events were similar to ours, but not exactly the same. Criteria was death, permanent harm, or serious temporary harm. 91% of the cases did not meet compensation eligibility. Those that did averaged a $75,000 payment, and only 5% of the events that they reviewed led to claims and lawsuits. Mello and Moore did a study published the same year, which was a qualitative study that asked patients and families what they thought of the process. They found that the support was timely, sincere, culturally appropriate, and meaningful, and taught people how to choose words that would promote reconciliation. I think we picked out, well, this is sort of the statistical analysis. This was actually asking clinicians what they thought of the program. About 70% thought that they felt supported by the process. Similarly, 70% strongly agreed that they were treated fairly during the process, and a little bit less, 64%, thought how fairly, I'm sorry. The first one was how fairly did program representatives treat the patient or family. The third was how the clinicians themselves felt that they were treated. But overall, pretty good results. And then Moore, same author from the previous paper, published another study in JAMA Internal Medicine in 2017 that was conducted at 3 hospitals, Stanford, Bay State in Massachusetts, and Beth Israel in Boston. They interviewed patients, family members, and staff, and the experience overall was positive for 60% of patients and their families. 35 out of 40 said that involving the plaintiff's attorney in those discussions was actually helpful. And many patients and families expressed an interest in knowing exactly what was being done by the hospital to prevent recurrences, but only 20% of them got that information when the hospital met back with them. That's something that we try to routinely share back with patients when we have made process improvements and we have identified opportunities. Pete and I pulled out a few quotes from that paper, which I thought were helpful. The first one's by a family member. What meant something to us was the people, like the resident, who actually cared. He wrote my daughter a letter and came to visit her. He wasn't afraid to actually reach out. That meant something to us more than an apology. Another patient said, the doctor listened and let me talk and talk and talk. I almost cried because it was the first time anyone really heard how I felt. He talked when I was done. It changed how I felt about the hospital. The physician wrote this comment, the attending should be in the room no matter how upset he is. I'm not half as upset as the patient or the family. This isn't about me. And we do urge the primary physicians involved to be involved in these discussions with the family at the end of the process. Some of the departments prefer to have a representative there instead. We have not polled the families yet to find out how they feel about that, but that is something that we might consider doing in the future. So now let's, in the last 15 minutes or so, look at our own results here. Again, just to remind you, because I think it'll help with the interpretation of the results, first is identifying the event, which is permanent harm or death. Then we have a phone call, a conference call where we all talk about it, all the parties involved. Then we go to the patient and do initial disclosure and begin the case review process. Then we bring it to the panel. In most cases, we bring it to the panel for their opinion on it, and after that, we meet back with the family. So I just wanted to reorient you to that, since it was many slides ago that I put that up before. So here are the a number of events by service line, and the biggest winners, if you want to put it that way, is the acute medicine service line that accounts for almost half of the events. That's between medicine, internal medicine here in the hospital, and the emergency room. That's what the acute medicine service line is. And then number 2 is surgical services, which actually is tied with heart and vascular. Well, no, surgical services, including trauma, is a little bit ahead of heart and vascular. And then the other service lines and essential services are far less in number. And then when we looked at the event characteristics, what were they due to? Some of them were related to a surgical procedure or a complication from a procedure. 28% of them were related to a diagnosis, and you may have been here for the lecture that Raquel organized through risk management about diagnostic errors. That was excellent. And then 20% of them were related to cardiac or respiratory arrest. Looking at the type of events, again, we said death or permanent harm. About 2/3 of these cases were unexpected deaths, and I think the information on the right-hand side of the slide summarizes this slide and the previous one. And this is based on, I didn't mention this yet, but 244 cases that we've looked at over the last 3 years. We've been kind of busy. This shows the volume by month, and from when we started the program in September 2015, so we're actually coming up on 4 years this September. We'll complete 4 years. It looks, I don't know if this will hold, but we did have a steady growth over time, but over the last year so far, it looks like we're starting to level out a little bit in terms of the number of events. This is data that Katie would be interested in. This is care for the caregiver volumes. Now, I have to tell you that these are not just related to CANDOR events. These are the calls of people reaching out to care for the caregiver regardless. They were involved in an event and they want that kind of support. But they also have been extremely busy with a huge jump in volume of 200% from year 2 to year 3. And then what happens when we bring it to conclusion? So as I said, our usual protocol is to bring this to the CANDOR review team, but you can see that only about 60% of the cases actually involve the review team. There are instances where we didn't have the review team involved, and that was when we had either clear-cut evidence that an error was made and everybody was in agreement, or we had some other multidisciplinary body like an M&M or something like that where the case we felt was adequately reviewed and there wasn't really a need to bring it to the panel. And this here shows the results when the cases did go to the panel. So instead of the previous numbers, now we're talking about 143 cases that went to the panel. And the first question we asked panel members is, were the generally accepted practice standards met? 60% of the time people said yes, and 41% of the time people said no. Of those 58 cases, if you then shift to the pie graph on the right-hand side, in which the standards were not met, about half of them said that the care itself did not contribute to the harm, and the other 41% said we did contribute to the harm. So the way I look at this is out of the 288 cases that we started out with, there were actually 24 cases where we felt something we did or didn't do for the patient resulted in the harm to the patient. That's the overall numbers there. So a little bit over 10% of or about 10% of the overall cases. And this here shows the fact that we've been challenged by the administration to try to bring these things to conclusion as quickly as we can. And the reason for that is that getting back to the family quickly has been shown to have a positive impact on how they react to what we're telling them, and we can get to resolution more quickly. So our goals now are to have a post-event debrief in these events within 5 business days, and we've been fairly successful most of the time getting those done within that time frame. And then we looked at various components of the program, and this kind of shows you the overall. So this is a process control chart, which I know there are members of the audience that love and adore as much as I do, to have to look at results over time. I think it's a very helpful way to look at it. So before we put some process changes in place, our average time from when we had the first alert of an event to when it went to the review team was 70 business days. That's a long time. And we reduced that to 33 business days in the post-intervention phase. And not only did we reduce the average time, but we were also able to reduce the variation. So the standard deviation decreased by 57, 58%. So we're very proud. Again, we haven't gotten additional resources in any of the departments for this program. One additional resource was that Pete became the program manager, and he whipped us all into shape. And I think he deserves a lot of credit for the improvements that we saw in the timeliness of the process. Now we're going to talk about the medical legal implications of this program. And I have to explain to you that because the statute of limitations on a lawsuit is 2 years in the state of Delaware, you can't get data on whether somebody is going to sue you or not right away. So the program's only been up and running, between 3 and 4 years. So we don't have that much data yet with regard to the medical legal outcomes. But on the right-hand side, you see the graph. There is a trend, I would say, towards fewer potential or actual lawsuits. And on the left-hand side, you see some other statistics that from the first 188 cases, which was the first 3 years, we had waived about $2 million in bills. We've had 12 lawsuits, 10 claims filed, and 6 of those were settled without litigation. The settlement total for 7 of the cases was about $1.7 million. And to date, if you look at it overall, the number of cases that we've identified through the CANDOR program, only 6% of the cases resulted in lawsuits. And we've seen no increase in the number of lawsuits. And again, that qualifier there about the statute of limitations. I will say that we have embarked on working with folks from the Value Institute to try to pull together more of this data to try to see what other metrics we should be looking at so that we can publish our own results similar to the University of Illinois and to University of Michigan. So some opportunities and future directions. I did not yet mention that in addition to the medical legal stuff, which is certainly the origins of these types of programs, we also view this as a patient safety program, and we have identified over 160 system improvements through the cases that we have evaluated. And there are some examples of them. I'll only point out one in particular, which is the revision of the Dobhoff insertion process. And for those of you who are not clinical, that's a type of feeding tube that is put into patients who can't eat themselves for liquid nutrition. And it's put in through the nose usually and down into the stomach. And we had a few events in which those inadvertently went into the airway instead and went into the lung and caused harm to the patient. So we, had our whole review of those cases. We came up with a new protocol based on some evidence-based guidelines from some other institutions. And since we have changed the process, we have not had another single incident of a misplaced Topov tube. So I think that's the kind of thing that we can accomplish by our review of these types of cases. Some future opportunities, some earlier identification of events. We still find out about some of these a little bit later than we should. Refinement and redefining our CANDOR alert process. We're trying to increase through presentations like this one today the awareness of this program across the system. We're trying to improve the efficiency and standardization of our review processes. We have to work in collaboration with the service line leaders and the event review teams. We've had a large effort headed by Michelle around psychological safety for our caregivers. This level of review and the fact that we're reviewing these things at the system level, sometimes after they've already been reviewed at the local level, people having to relive these experiences where they already feel badly about the outcome for the patient and perhaps feel badly about their own involvement in that event, certainly causes increased stress. So in addition to the Care for the Caregiver program, which is sort of, after the fact, we're trying to be proactive and trying to educate frontline managers, medical and nursing primarily, on how to approach their staff when an event like this occurs and tell them that they're going to be asked to come to a debrief and what that debrief is all about. So we've developed some scripted language and some job aids for those folks to use, and there will be other things that are coming out of the psychological safety work group to try to begin to set the stage better from the very beginning of when these events occur. And in terms of future opportunities, I already mentioned that we're working with some folks from the Value Institute, but we're also trying to collaborate with other people around the country. So there's a group working on creating a consortium and then collecting metrics collectively from different programs around the country. This group is being run by the Ariadne Labs and the Collaborative for Accountability and Improvement. As a matter of fact, this afternoon, Pete and I have a phone call with one of the leaders of that effort to see if we can contribute our data to their system and to see what we can learn from it and how it might help us in terms of what metrics we should be collecting moving forward. And then this is a summary of some of those metrics that comes directly from their literature that was presented recently at the IHI meeting. In addition, I added a little box in there for some of the Care for the Caregiver metrics to really see what we've accomplished with that program. These are not easy metrics to measure, staff retention or staff movement from one place to another, but that is one thing that we thought of that we could potentially measure. Asking people what their experience was and stuff like that, since the whole Care for the Caregiver thing is done anonymously, it's a little bit difficult to ask them to share their experiences in that way. So I do have 5 minutes left for questions or comments, and I want to thank you all for your attention. And I was told, and I do follow instructions very well, that at the end of the presentation, after the references, that I'm to put up the slide again to tell you how you can get credit for sitting through 1 or 50 minutes of me talking at you. So, questions or comments? Yes.
The CANDOR cases, patients or
Yeah, that's a great question. We have not, I don't think, matured to that state yet, but you're definitely on the right track, because there are places around the country that are involving patients and patient family members in even the root cause analysis meeting or the debrief meetings, because they may have seen things or made observations that nobody else was in the room with the patient to see at the time. So we hope to get there at some point. We have somebody from, I think she came from the Patient Advisory Board, the woman who comes to the panel meetings and helps us take the minutes and stuff like that. So we do have somebody involved from Patient Advisory, but not the patients involved in the actual events, not as of yet. But something to be thinking about for sure. Any other questions, comments? Michelle, Susan, any final words?
No, the only thing that, one, it takes really the collaboration of professional departments that we mentioned, but recently, it's another topic, but Heather Farley shared an article, and I'm forgetting who the author was, but it was about third victim. And we talked about that at our last meeting, psychological. The third victim really are the professionals who are doing this work. I know there's lots of mixed feelings in the literature about even coining the term the second victim from the patients who have experienced this on the family. Now there is some work being done around third victim. From the perspective of, it's pretty comprehensive. From the perspective of that either, you're trying to get system improvements made and push stuff as a priority within the organization, or it's just your repetitive about someone who. I thought it was really,
It was very insightful. We try to support one another, but it is true, you can get this view from what we see that, things are always going badly, but it's a very small percentage of the patients that we take care of overall. So we try to support each other. Alcohol is also very helpful at times. We try to celebrate having happy hours when we get to certain milestones and things like that. So, well, thanks for listening.